Hi, Ninja Nerds. In this video, we're going to talk about angiotensin converting enzyme inhibitors, also known as ACE inhibitors, as well as angiotensin II receptor blockers, also known as ARBs. So let's go ahead and get started. All right, so before we start talking about the different types of ACEs and ARBs, their mechanism of action, their indications, side effects, and a couple contraindications, we have to understand the Renin-Angiotensin-Aldosterone system. Because if we do, all the ACE inhibitors or ARBs are going to do is block that normal physiology. So let's briefly kind of fly through our normal Renin-Angiotensin-Aldosterone system. So how does this all work? Basically, you have specific cells in the kidney, right? And they're going to be right around the afferent arteriole. They're called the JG cells, right? And these are renin-producing cells. Whenever there's low blood flow or decreased perfusion through the renal artery going to those JG cells, it stimulates the JG cells to release a specific enzyme called renin. Now, renin is a very beautiful enzyme, and what renin does is it converts a protein made by the liver. You know, the liver makes a protein called angiotensinogen, and what renin does is he cleaves a portion of angiotensinogen, he cleaves a couple amino acids off of it, and activates it by turning it into angiotensin 1. Then angiotensin 1 runs through the circulatory system and goes to the lungs. In the capillary endothelium of the pulmonary system, there's another enzyme called angiotensin converting enzyme, also known as ACE. This enzyme, what it does is it takes and stimulates angiotensin 1, cleaving off another particular amino acid sequence, and converting this into angiotensin 2. Angiotensin 2 is an extremely potent vasoconstrictive agent. So again, how do we start? Renin, due to decreased perfusion or decreased blood flow to that area, that stimulates the renin production from JG cells. That cleaves angiotensinogen into angiotensin 1. Angiotensin 1 goes to the capillary endothelium of the lungs, where ACE is, which converts angiotensin 1 into angiotensin 2. Angiotensin 2 has multiple different effects on the body. Let's talk about a couple of them, right? One of the things you need to know is that there's angiotensin 2 receptors present on the vascular smooth muscle. So we have angiotensin 2 receptors, right? These angiotensin 2 receptors that are found on the actual vascular smooth muscle, when angiotensin binds to them, it causes those smooth muscles to contract. When they contract, it triggers what's called, so their smooth muscle contracts, and after that smooth muscle contracts, the tunica media, it leads to vasoconstriction. You know, whenever you vasoconstrict a vessel, you decrease the diameter. Whenever you reduce diameter of the lumen of the vessel, the blood flowing through that encounters more resistance. If you increase total peripheral resistance, you thereby increase blood pressure. That's one way. And if we increase blood pressure, technically we're going to increase blood flow through the kidney. That's the whole reason this whole mechanism works. The other way is that angiotensin 2 is going to act on a specific area of the pituitary, right? So you know, within the pituitary, you have two components, the anterior pituitary and the posterior pituitary. Angiotensin 2 stimulates the posterior pituitary. The posterior pituitary will release a specific hormone called the antidiuretic hormone. The antidiuretic hormone will then go to the kidneys. When it acts at the kidneys, guess what it does? It stimulates, it puts in little aquaporin units, right? And by doing that, it increases water reabsorption. If I increase water reabsorption, I technically will increase blood volume. And by increasing blood volume, that increases my blood pressure. Okay. The other thing is angiotensin 2 also stimulates specific cells called the zona glomerulosa on the adrenal cortex, and stimulates the zona glomerulosa to release what's called aldosterone. Aldosterone is a mineral corticoid. It acts on the kidneys, right? Particularly at the distal convoluted tubule, whereas ADH works at the level of the collecting duct. Aldosterone acts at the distal convoluted tubule, and it works to increase water reabsorption, particularly by increasing sodium reabsorption. By doing that, if you pull more sodium and water into the bloodstream, you increase your blood volume. And if you increase your blood volume, what's that going to do? That is going to increase your blood pressure. The other thing that you got to remember is, guess what else aldosterone does? Aldosterone also does something else. He stimulates, and when you do sodium reabsorption, it also initiates potassium excretion. And if there's potassium excretion in the urine, then what does that mean? That can lead to hypokalemia. So they could have hypokalemia whenever there's too much aldosterone, as well as hypernatremia, high sodium levels, and hypertension due to increased water and sodium, increasing blood volume and increasing BP. So now that we understand this whole mechanism of the renin-angiotensin-aldosterone axis, we can just talk about how the ACEs and ARBs block these effects. All right, so now let's go ahead and talk about the mechanism of action of these drugs. It should be very simple, guys. Let's blast through this. Remember, there's decreased blood flow or decreased perfusion through the renal artery, stimulates the JG cells, right? The JG cells respond to this by making renin. The liver makes what's called angiotensinogen. It's produced by the liver naturally. Renin converts angiotensinogen into angiotensin 1 by cleaving off a specific amino acid fragment. Now, angiotensin 1 will then travel through the blood to the capillary endothelium of the pulmonary system, where angiotensin converting enzyme is. That's interesting, right? Because we know about the drugs called ACE inhibitors. Well, angiotensin converting enzyme, we know that he helps us stimulate the conversion of angiotensin 1 into angiotensin 2. So if we use drugs like ACE inhibitors, which we'll talk about the different types, we're going to inhibit this enzyme. If you inhibit the ACE enzyme, then are you going to be able to convert angiotensin 1 into angiotensin 2? No. So that means that you'll have a decrease in angiotensin 2. Well, let's think about this then. It has three primary effects that we focused on previously, right? One is it acted on the blood vessel, right? Particularly on those angiotensin 2 receptors. Remember these? Whenever it acted on it, it primarily caused vasoconstriction. But you're not going to have vasoconstriction now. You're going to have the opposite because it's opposing this. That's going to lead to vasodilation. Vasodilation is going to lead to what? An increase in the diameter of the lumen. So now there's less resistance that blood is going to encounter. And if there's less resistance, that's going to drop the blood pressure. All right, that's pretty cool. Second thing, angiotensin normally stimulates the posterior pituitary, right? The posterior pituitary to make ADH. Now, if you are having decreased angiotensin 2, you're not going to stimulate the posterior pituitary as much. There's going to be decreased ADH production. If there's decreased ADH production, what does that mean to the kidney? That means that there's going to be less water being reabsorbed. If there's less water reabsorption, that's going to result in a drop in the blood volume. And a drop in the blood volume is going to result in a drop in the blood pressure. What else? If we actually inhibit particularly another area, the zona glomerulosa. Remember, the zona glomerulosa was responsible for making a hormone called aldosterone. Now, if there's less angiotensin 2, there's less stimulation of aldosterone. So there's a decrease in the production of aldosterone. Less aldosterone means that you're going to have less what? There'll be a decrease in sodium, and there'll be a decrease in water reabsorption. And if there's a decrease in this, that means that there's a decrease in the blood volume and therefore a drop in the blood pressure. In addition, you're also going to be inhibiting aldosterone. Remember, it increases the sodium and water reabsorption, right? But and then also by doing that, it causes potassium excretion. Remember, we said that previously. Well, if we block that effect, we're not going to excrete the potassium as much. So now potassium could potentially build up in the blood, and that could lead to hyperkalemia, which is a potential side effect of ACE inhibitors. So we know how ACE inhibitors will work. What about angiotensin 2 receptor blockers? Where does angiotensin 2 receptor blockers work? at all of these sites. So if I give an ARB, it's going to inhibit this reaction. If I give an ARB, it's going to inhibit ADH production. If I give an ARB, it's going to inhibit aldosterone production. You see how that all works? Now, another thing you have to realize is that whenever there's vasoconstriction, right? Whenever there's vasoconstriction, what does that do, right? It increases total peripheral resistance. Whenever you increase total peripheral resistance, what does that do to the afterload? It increases afterload, right? Theoretically. Because now the pressure is going to build up proximal to wherever that constriction point is. Well, that's going to put stress on heart, okay? It's going to stress the heart. And if someone has heart failure, if someone has coronary artery disease where their oxygen demand is already really low and you don't want to increase the stress on the heart even more, or if someone has very strong normal vasoconstriction, like they have a very strong isolated systolic hypertension, wouldn't these drugs be pretty beneficial, like ACE inhibitors and ARBs? Why? Because they decrease angiotensin II production, right? So think about this now. If we give, okay, let's go back to angiotensin II. It caused vasoconstriction, right? If we give an ACE inhibitor or we give an ARB, what are these going to do? They're going to lead to a decrease in angiotensin II production. That's going to result in less vasoconstriction. If there's less vasoconstriction, there's a drop in the total peripheral resistance. There's a decrease in the afterload, and therefore a decreased stress on the heart. Isn't that beautiful, that way that works? In the same way, you guys remember, angiotensin II also did something else, right? It led to increased ADH and increased aldosterone. And if you remember, both of these collectively increase sodium and water, which increases blood volume. Well, if you have more blood circulating through the heart, what does that do to your preload, the amount of blood that's returning back to the heart? It increases because you have more blood volume. That means an increase in the preload. And if you increase the preload, technically you can increase the EDV. And by increasing the EDV, you technically, if the heart is already stressed from heart failure, from having hypertension, from maybe a previous myocardial infarction, coronary artery disease, something like that, it can put more stress on the heart. So by doing that, you increase the stress on the heart, right? So let's put an up arrow here. Now let's try to make sense of it all. If you give an ACE inhibitor or an ARB, what do you technically do? Well, you decrease angiotensin II, whether it's decreasing production or blocking at the receptor sites. So that's going to lead to what for the ADH? It's going to lead to decreased production of ADH, decreased production of aldosterone. That technically leads to a decrease in the sodium and water reabsorption collectively. More specific sodium for aldosterone, water more specific for ADH. But either way, the whole of the result is the same. You decrease sodium and water, you decrease blood volume. You decrease blood volume, you decrease the preload on the heart. You decrease the preload, you decrease the EDV, and you potentially can decrease a lot of that extra stress on the heart. So that should make so much sense now why these drugs are really good. All right, so now let's go ahead and talk about the different types of ACE inhibitors and ARBs. All right, so now let's go ahead and talk about the different names of a lot of these ACE inhibitors that you might see, or angiotensin II receptor blockers that can come up. So names. The best way to remember the ACE inhibitors is they usually end in pril. So just like beta blockers end in alol, the ACE inhibitors will end in pril. So what are some of them? Benzapril, captopril, Enalapril, and Lisinopril. So these are some of those ACE inhibitors, angiotensin converting enzyme inhibitors. Now, angiotensin II receptor blockers, again, they're pretty much the same, just like ACE inhibitors. They're pretty great drugs. It's just we'll talk about in a second that usually only time you use ARBs is if ACE inhibitors are not working for a patient. We'll talk about why. Usually it's because of like angioedema or a dry cough. So angiotensin II receptor blockers, these ones usually end in tan. So this would be like Candesartan. So you see that tan at the end. Losartan and Valsartan. Okay? So these ones, again, angiotensin 2 receptor blockers. So ACE inhibitors, benzapril, captopril, enalapril, lisinopril. If you forget them, just remember they end in pril. Angiotensin 2 receptor blockers, Candesartan, Losartan, Valsartan. If you forget them, remember they end in tan. Okay? It's easy whenever it comes up on an exam to remember that. All right, now that we know the name of the drugs, their mechanism of action, let's go ahead into their indications. All right, so let's talk about the indications here. We know that they're great in basically helping to reduce blood pressure. That was obvious in a lot of the mechanism of action, right? So if it's good in dropping blood pressure, what kind of condition do people have when they have high blood pressure? It's called hypertension, right? So it's great for people with hypertension. Okay? Now, it's important to mention that there is patients, African Americans, as well as older individuals who have what's called low renin hypertension. So in other words, their angiotensin 2 isn't super high. So because of that, these kinds of drugs aren't really super beneficial for that population. So if you are having someone who's like African American or they're Caucasian who have a lower renin hypertension, they're probably going to respond better to diuretics or calcium channel blockers like nifedipine or amlodipine. But either way, hypertension is one of the indications for this because it can drop pressure. The other thing it's great for is, remember we said that if you can decrease afterload, that can decrease some of the stress on the heart? Well, there's two good reasons why you would want that. What if someone has an underlying coronary artery disease, or they recently had an MI? It could be good for that because their heart is already stressed. Decreasing that stress and that oxygen demand will help to benefit that. So that would be one thing if someone has coronary artery disease. And more specifically, let's just say that they had a recent or previous MI. These are actually beneficial drugs for that after someone's had an MI. The next thing is if someone has heart failure. Why? If someone has heart failure and you try to reduce that afterload, that's very helpful, especially if someone has systolic heart failure, because the pump's already weak. If you decrease the afterload, it's going to make it a little bit easier for them. Also, if a heart's already weak and you try to increase the oxygen demand on them, that's going to make it worse, because you're giving them more preload, you're giving them more afterload. That's going to really stress that weak heart out. So if you reduce the preload, reduce the afterload, reduce the oxygen demand, it can really make a big difference in heart failure. It's one of the first line treatments. Another thing that we've also seen with ACE inhibitors and ARBs is that they're good for patients with kidney disease, particularly those who have a lot of proteinuric kidney disease. So one of the big ones here is diabetes. So if someone has diabetic nephropathy, right? In diabetic nephropathy, they lose a lot of protein in their urine, right? They lose a lot of albumin in the urine. So what we can do is we can give ACE inhibitors and ARBs, and what they've been found to do is actually decrease some of that protein in the urine. And that's pretty cool. That is very beneficial. You decrease the protein within the urine, that's very effective. It helps to decrease the continual damage from it. So it's nephroprotective another way in patients who have diabetes. So if someone has diabetes and you want to protect their kidneys from losing a lot of protein, you can give ACE inhibitors or ARBs. They're really good for that. All right. Next thing, let's talk about another thing called cardiac remodeling. Okay, so whenever someone has had a heart attack, they have heart failure, or they have chronic hypertension, it can cause cardiac remodeling, right? And that can be bad on the heart. It puts a lot of stress on the heart, increases a lot of fibrous tissue formation. Overall, it leads to a decrease in the pumping function of the heart. And this is especially important after a heart attack, okay? So let's talk about this. Remember the kidneys, they make renin, right? Renin, if you guys remember, will convert angiotensinogen made by the liver, right? So you have angiotensinogen. It'll convert this into angiotensin 1. Angiotensin 2 will then get converted via the enzyme ACE in the capillary endothelium of the lungs into angiotensin 2. And this will stimulate aldosterone production and it'll stimulate ADH production. We know that regardless, increased aldosterone production and increased ADH production result in what? We already kind of talked about this. It's that there is an increase in sodium reabsorption and an increase in water reabsorption. What does that do to the blood volume? As a result, that's going to increase the blood volume, and that can increase preload. And if we increase preload, what do we do to the heart? We increase the stress on the heart, right? On an already weak heart. Same way, remember that angiotensin 2 can also act directly on those blood vessels, right? And what does it do? It causes vasoconstriction. The overall effect of vasoconstriction is an increase in total peripheral resistance, and that increases afterload. And if we increase afterload, again, you increase the stress on the heart. Any increase in afterload or any increase in preload in an already weak heart can induce what's called cardiac remodeling. What we want to do is to reduce that cardiac remodeling. So how do we do that? We give ACE inhibitors and ARBs. Why? Because that decreases angiotensin 2 production. That leads to a decrease in the total peripheral resistance, a decrease in the afterload, and a decrease in that stress on the heart. It leads to decreased aldosterone production, decrease in ADH, which results in a decrease in sodium, decrease in water, decrease in blood volume, decrease in preload, and an overall decrease in stress on the heart. If we decrease afterload and preload, what do? We decrease cardiac remodeling. So again, this is one of the beneficial things of ACE inhibitors and ARBs is they decrease afterload and they decrease preload. And again, this goes hand in hand with cardiac remodeling. These are great for those who've had MIs because it helps to decrease a lot of the remodeling after there's been a myocardial infarction or someone who has chronic hypertension. These are the indications for ACE inhibitors and ARBs. Now let's go ahead and talk about some of the potential side effects. All right, so now side effects. Let's make this very simple. You guys will never forget this mechanism, right? The kidney makes renin. Renin is actually going to cleave angiotensinogen into angiotensin 1. Then ACE will convert angiotensin 1 into angiotensin 2. That stimulates aldosterone production, right? We're going to focus primarily on aldosterone. Going back to what we said about aldosterone, what does it do to the kidney? It increases sodium reabsorption and it increases water reabsorption, right? And that's eventually going to lead to an increase in blood pressure through increase in blood volume. But what else did we say it could do? It causes potassium excretion. And if we excrete potassium, what does that do to the blood potassium levels? It decreases, called hypokalemia. When we give an ACE inhibitor or an ARB, we basically decrease angiotensin 2 production, decrease aldosterone production, or block angiotensin 2 on aldosterone, producing aldosterone, regardless whether it be ACE inhibitor or blocking angiotensin 2 stimulating production of aldosterone. Decrease in aldosterone results in less sodium and water reabsorption, which can result in a drop in blood pressure. But also it leads to less potassium being excreted. And so the potassium can potentially build up in the bloodstream. What's that called? Hyperkalemia. So a potential side effect of being put on an ACE inhibitor or an ARB is hyperkalemia. And that's important to make sure that you monitor because it can lead to severe dysrhythmias. One of the classic signs is like peak T waves. The next thing is potentially, think about it, you can put on an antihypertensive drug. If you give too much of it, what's another potential side effect? Hypotension. So you could potentially drop the person's pressure as well. All right, so the last side effect that I want to talk about that you commonly see with ACE inhibitors, not ARBs, is angioedema, which is a severe reaction to ACE inhibitors. We'll talk about another thing that can increase the risk of that, hereditary condition, as well as a cough, a dry cough. In order for us to understand that, we have to go through this bradykinin pathway. So really quickly, I'm going to take you guys through it. There's a molecule, a protein called prekallikrein. Okay? And prekallikrein is converted into kallikrein, right, through specific enzymes that regulate that step. One of the enzymes is called a C1 esterase inhibitor, and the other one is going to be called factor 12A, right, which is a protein from the coagulation cascade. The factor 12 wants to stimulate this pathway, whereas the C1 esterase inhibitor wants to decrease the activation or formation of kallikrein. Now, if kallikrein is made, kallikrein is an enzyme that converts what's called high molecular weight kininogen into what's called bradykinin. Bradykinin works by causing a couple different effects. One is it can work on the vascular smooth muscle within the bronchioles and induce what's called bronchoconstriction. And what that can do is that it can cause respiratory difficulty. It can cause cough, and it can cause respiratory distress, right? Because if you're constricting those bronchioles, you're making it hard for air to get in. The other thing is it can increase capillary permeability as well as vasodilation. So you're going to get an increase in cap permeability, and you're going to get an increase in blood flow to that area. The collective effect here is going to be edema and swelling, right? And that's what happens within the upper respiratory tract and within the lower respiratory tract potentially. The other thing is that this bradykinin can also stimulate certain nerves and lead to pain. So you can get a cough, you can get angioedema here, which is this edema effect due to increased vasodilation, capillary permeability, fluid leakage, and therefore edema, as well as pain and cough and a little bit of respiratory distress. There's another molecule that's very important that regulates the activity of bradykinin, and that is called angiotensin converting enzyme. Guess what this enzyme does to it? It tries to inhibit bradykinin production. If I give an ACE inhibitor, guess what else I do here? An ACE inhibitor, if I give one, will inhibit this ACE enzyme, right? If I inhibit ACE enzyme, I'm no longer going to be able to inhibit bradykinin production. So now bradykinin production will be stimulated. If I lead to high bradykinin production, that's going to increase bronchoconstriction leading to cough. It's going to increase capillary permeability and vasodilation leading to angioedema potentially. And also it can increase pain. Here's another thing that's also interesting. Remember this enzyme, C1 esterase inhibitor? There are certain people who have an autosomal dominant condition where they have a deficiency in that C1 esterase inhibitor. If there is less of this C1 esterase inhibitor, what does that mean? That means you're not going to be able to inhibit the conversion of precalcirin to calcirin. That means that this will lead to increased stimulation. So I'm going to have increased calcirin, which is going to convert a lot of high molecular weight kininogen into increased bradykinin. That increases bronchospasm, increases edema, and increases pain. Now, if someone has a C1 esterase inhibitor deficiency and they're on an ACE inhibitor, could you imagine how severe this could be? That's a potential contraindication of the drug, is someone having a C1 esterase inhibitor deficiency. So, big side effects that I want you to remember: hyperkalemia, hypotension, and with ACE inhibitors, it can lead to cough or angioedema, and it's contraindicated in a C1 esterase inhibitor deficiency. All right, so last thing I want you guys to remember is contraindications to using ACEs and ARBs. Obviously, one is angioedema. If you give someone an ACE inhibitor, they have angioedema, you can't give it again. We already talked about that. The next thing that you have to also be aware of is that if someone is pregnant, you can't give this to pregnant patients. The reason why is it's been shown to lead to congenital malformations. So it's potentially teratogenic. So instead of putting them on an ACE inhibitor or an ARB, put them on something else. Maybe hydralazine, maybe methyldopa, maybe nifedipine, maybe labetalol, okay? The other thing is drug interactions. Obviously, some people aren't going to respond just to an ACE inhibitor or an ARB. Some people might need multiple hypertensive medications. If that's the case, you just have to be careful because obviously as you give more antihypertensive drugs, there's a risk of hypotension. So that's something also to be aware of. The other thing is that you want to be careful with what's called potassium sparing diuretics, like spironolactone. Why? Because spironolactone, if you guys remember, what does it do? It's an aldosterone antagonist. It basically blocks the effect of aldosterone. If you block the effect of aldosterone at the kidneys, you're not going to be able to excrete potassium. Potassium builds up. If you have an ACE inhibitor and them on spironolactone, that could potentially increase the potassium enough to cause severe hyperkalemia. So you have to be wary about high potassium when putting them with an ACE inhibitor or ARB and a potassium-sparing diuretic. The other thing is NSAIDs. NSAIDs might counteract everything you try to do with an ACE inhibitor because they might increase sodium and water retention. If you increase sodium and water retention, you increase blood volume and therefore blood pressure. So it can have that counteractive effect. The other thing is lithium. So lithium used in bipolar disease. When you give ACE inhibitors or ARBs, it actually has the ability to decrease the elimination of lithium. And so lithium levels could potentially build up. That's another thing to watch out for. Lastly, if we talk about specifically if someone has plaque development within the renal artery supplying the kidney, what's that called? If they have stenosis or narrowing, it's called renal artery stenosis. What if they have bilateral renal artery stenosis? That would be one reason why. The other thing is if someone has kidney failure, really bad kidney failure, and severe chronic kidney disease, we have to be careful with ACE inhibitors and ARBs because they could potentially make things worse. Okay? So these are the contraindications and drug interactions to also be aware of. Last but not least, we talked about this just briefly before. If someone has an autosomal dominant condition, meaning they have one mutant copy and one normal gene on the two different types of chromosomes, they can have what's called a C1 esterase deficiency. So in C1 esterase inhibitor deficiency, which we already talked about previously, you do not want to give somebody ACE inhibitors. All right, so I just want to quickly explain, the last thing here is why, if you put someone on an ACE inhibitor or an ARB, would it be bad or contraindicated if they have severe chronic kidney disease or renal artery stenosis? Think about it. You give them an ACE inhibitor or an ARB. What are you doing? You're basically inhibiting angiotensin II production. Angiotensin II does what? It causes vasoconstriction, which increases blood pressure, which increases perfusion to different organs like the kidneys. The other thing is that you're going to be decreasing aldosterone production and decreasing ADH production. That's decreasing blood volume. Less blood volume means technically less blood pressure and less perfusion through the kidneys. So if the kidneys aren't getting enough blood flow already, and you decrease their blood flow and even more by giving them an ACE inhibitor or an ARB, it can worsen their already chronic kidney disease or worsen their renal artery stenosis. And that's not something that we want to do. All right, listeners, so in this video, we talked about ACE inhibitors and ARBs. I hope this video made sense. I hope you guys did enjoy it. If you guys did, please hit that like button, comment down in the comment section, and please subscribe. Also, if you guys get a chance, down in the description box, we have links to our Facebook, Instagram, and Patreon. Go ahead and check those out. All right, listeners, as always, until next time.